Any question from the audience? Okay. So, Dr. Adler, I have a question for you. So, like when you go arthroscopically in the subacromial space, the deltoid from the subacromial space, the space between the humerus and the glenoid, is not constrained. So you have the humerus, the glenoid, the deltoid. You have all the space, posterior and lateral. So when you put this balloon between the acromion and the humerus, what will stop it from slipping distal and lateral? Lateral and posterior. You have a huge space. It's a very big space. What happened to it?
You have anatomy a little bit different that was described by you now. Because we have a corner that is arranged by the basis of the acromion on the lateral part. We have the superior part of the coracoid on the anterior part.
Yes.
So we have a space. From above this space, you have the acromion.
Yes.
And you have the acromio-coracoid ligament. It is a corner. So if you take non-inflated ball, put it in a corner, you can hit it as much as you can, it will stay in the corner. Because the balloon is very not tense one, because you inflate it and deflate it back. So you have a non-inflated balloon pushed by the head into the corner. And if you look of the net reaction forces, they are directed into this corner. So like a head, it will always keep the balloon at its place.
Okay. All right. Sure.
Good morning.
Yes, yes, go ahead.
My question to Dr. Bosiadis. Now, like for me, irreparable cup means like a patient will be coming to you after 4 to 6 months with muscle atrophy, lot of fatty infiltration. Okay, and we have seen that in such kind of patients, either there will be some auto rupture of the biceps tendon, they will be having some slap tear, or sometimes there will be a paralabral cyst. So what you will do like in such cases, like if you're irreparable cup?
So in these cases, I'm all if it's degenerated, the biceps, I'm always using it. I found that this is not probably the degeneration of the biceps. So if you take it out from the bicipital groove, despite that some study says that all the nerves at the glenoid side, the patient stops to have pain. So even if it's severely degenerated, I'm always using it. So from the other side, slap lesions to be detached in a massive rotator cuff tears, I have never seen that it's a great slap lesion and it's detached. However, I have 2 cases with traumatic musculotendinous lesions with real slap lesions from the posterior superior, and I have always repaired the slap posteriorly, and I have performed superior capsular reconstruction with the biceps and augmentation of the musculotendinous junction massive rotator cuff tear, and these patients are very good, very, very good.
So I have a question for you as well. I was surprised about like your infraspinatus because in a lot of young patients, the infraspinatus is gone, really gone. They have very advanced fatty atrophy. So what do you do for these patients?
So we included patients only with fat infiltrations, only 2, not fat infiltrations.
But what happened for those patients in your practice? If you have this patient in your practice, what would you do?
With fat infiltration greater than 2, probably I would think a tendon transfer if it's young, but if it's older, reverse, older arthroplasty. Okay. And for the reverse, I'm looking at the terminoscope, what's going on to make a transfer at the same time.
So Teru, I have a question for you. Okay. I always argue with him, by the way. Me and Teru all the time. So as a concept, you've seen brachial plexus patient before? Patient with brachial plexus injury?
Never.
Okay. So brachial plexus patient, if you see them, you can take the shoulder, move it everywhere.
Okay.
It's completely loose.
Right.
You can go up,
Right.
down, front. So even the concept, all the concept of stability we talk about, it requires the compressive effect of the rotator cuff, the capsular complex, because it become important if you have muscle.
Okay.
Without muscle, it's not important anymore because the humerus almost go outside the labrum. So for me, when you said about the superior capsule, I'm talking only as a concept.
Okay.
If you have no muscle, it's loose. You can move the shoulder the way it is. So when you talked about superior capsule reconstruction, and we know the capsule thickness is not more than 2-3 millimeter, but your graft is a centimeter. Can you tell me the terminology? This is not a capsule. When you say superior capsular reconstruction, the capsule is 2 millimeter. This is a centimeter. So why is it called superior capsular reconstruction?
Yeah, thank you very much. That is a good question. Actually, I reconstruct not only the capsule, actually tendon part too on the humeral head. But the medial side, I cannot reconstruct actually because the muscle part. But I want to make the reconstruct not only capsule tendon part too. So maybe the similar thickness. And actually, thickness is some important, but why I recommend the thicker graft because it's not specific tension effect. I believe of the shell to make a good tension of the graft. I need a very stiff graft. Yesterday I told you, and actually, but 2 millimeter, 4 millimeter, it's actually I tried before, but it's not. We cannot reconstruct a very good stability. That's why now I recommend this 8 millimeter thickness.
Yes, thank you. Yes, Clara. Yes.
As Professor Mirhata also showed in his slides about the anatomical studies from Nimura in 2011, and they did another study in 2018, it's just not only a question of the thickness, but about the width of the footprint of the capsule. That's really important, and this is reconstructed with the superior capsule reconstruction. You reconstruct the footprint of the capsule. This is very important for the stability of the shoulder, and then when you reconstruct the force couples, the horizontal force couple of the subscapularis with the teres minor and the infraspinatus, you are performing a superior capsular reconstruction. I understand your question about the thickness. Maybe it's too much, but maybe it will be proven that the question is you don't have supraspinatus. So maybe you're trying to compensate for the fact there is no supraspinatus with more thickness. I don't know.
Clara,
but
sorry,
but
I don't
you
wanna-
cannot say it's not a superior capsular reconstruction because of the thickness, because you have the width. That's what I wanted to add.
I disagree, sorry. Because I'm with you with everything, but it's not correct. Explain to me then, if you have if you have brachial plexus, you can move in anatomic shoulder, the shoulder that God gave you.
I will.
Yes, you can move the shoulder completely
Yes,
up. Yeah.
but we are not treating brachial plexus patients.
I'm not talking about brachial
They are
plexus, I'm talking about anatomy.
Yes,
Anatomy,
but
the
the
superior
anatomy-
capsule usually is not.
I understand
I'm
what
talking
you're
about the
asking.
terminology only. I'm not arguing about I'm just saying the superior capsule is very thin. We know that.
Yes.
And you can move it if you don't have a tendon.
Maybe I'm not explaining myself. Question is, we're treating patients that have the other muscles functioning. This is an
understand.
indication.
Yes.
So one exclusion, a contraindication for this procedure is if you have a brachial plexus, precisely because of what you said, because in order for the superior capsule to contribute, it needs the other muscles. You need to allow for the scapular stabilizers to contract to initiate the abduction, and then the deltoid needs to have the glenohumeral joint centered, and for this you need the capsule and you need to reconstitute the force couples. You need the muscles, so you cannot treat like this way a brachial plexus patient. That's why the biomechanical studies are valuable, but they don't give all the information. You need clinical studies because you have live patients contracting their muscles and benefiting from the procedure.
Okay. Yes, doctor.
I want to join your question. Anatomically, we have no capsule connected to the glenoid. Sorry. We have capsule maybe connected to the humerus. On the glenoid side, we have nothing. Maybe it's somewhere in the middle part. So now we put something between the head and the glenoid. It should be called tenodesis.
You know what? I'm so sorry I posed this question. I'm just trying to talk about terminology. I'm sorry. I did not mean to cause all. But it's nice to have discussion. It'll be fun. It's very boring. That's to say, yeah, you're right. This is all so nice. It's nice to have discussion. It's nicer. Yeah.
It's good that you joined because now I'm not the only one.
We have, yes. Yes.
May I discuss something about the balloon? When we started this procedure, we do it like a single procedure, just insert balloon, and that was all. Then we thought that additional partial repair of the infraspinatus is beneficial, and we are doing this. Now your study shows that there are no differences between those two options. My first question is, do you check is there a re-tear on the infraspinatus? Because Dr. Mihata shows that you have some re-tear rates after the superior capsular contraction. This is my first question. My second question is, do you have a different rehabilitation protocol between those two groups? You know, because we forced to patients with with balloon insertion to go to the rehabilitation as soon as possible, and for the another group maybe it's not true.
For the second question, the rehabilitation program was the same for the two groups, but I have to repeat that the difference is that the first group has a balloon plus partial repair, and the second group only balloon. So we started immediately active assisted rehabilitation as the patient tolerated. So it was the same program for both groups. About the re-tear rate, we don't take it with an MRI, not to this study, but from the clinical examination, there is not any decreased to the functional score or to the external rotation or external rotation lag significantly to any of our patients from this series.
Yes, go ahead. And he wants to talk as well.
In this study, it is a retrospective study. So what we did is we take the patients that are operated and see how they are doing. And we did, and so the decision to do a partial repair or no repair was taken during the surgery. If we could repair, we repaired it. If we could not repair, we just implanted the balloon. And we expected that the patients that were repaired would have a better outcome. But they had the same in this study. It's a small group of patients, and we can extrapolate the result. But still, this is an observation, and this is what we had. And because the idea of balloon is about functional improvement, not anatomic improvement, we didn't check with MRI. We expected to see, again, a torn rotator cuff as before the... We don't know if we had a less active rehabilitation, maybe we had better results with the partial repair. The partial repair broke because the rehabilitation was too active. But the idea of the balloon is to have an active rehabilitation quickly. So this is what we prefer to do.
Excuse me, I have to make a question to all the panelists, and next I will take you. That goes to every speaker, to all speakers. Intraoperatively, did you find any changes, degenerative changes in terms of arthritis of the humeral head that stops you from going on to the plan everybody has, or to an alternative surgery, or you leave it as it is, or you go for the balloon, maybe? Could everybody?
So to our studies, the patients with arthritis were excluded, so...
I believe we should get all the possible data before the operation and decide about the operation before the operation. If we have a surprise during the operation, we should act according to new diagnosis, even if we have to stop this procedure.
Well, sometimes there is a lag between the preoperative imaging, the MRI and the X-rays that give you that information on the glenohumeral cartilage status. So if intraoperatively I find more degenerative changes than I expected, if I proceed with the same plan because I want to give the patient an opportunity to have a joint sparing procedure, and also because there's informed consent, I cannot change the procedure without having discussed that previously with the patient.
Yeah, so for the issue using osteofascial, actually, if I see the mild osteoarthritis, not so severe osteoarthritis, in that case, I keep doing the issue. But it's just cartilage defect, some cartilage defect. If we do the issue, I can get good clinical outcome, no pain at all after surgery. But if the patient has severe bony deformity, maybe I do total shoulder plus issue or reverse.
So the same way when I have small degenerative changes of either at the glenoid or the humeral site, I continue with the biceps. If there are more severe or osteophytes, the lower part of the, I found osteophytes at the lower part of the humerus, I am stopping it.
Yes, go ahead.
Thank you. I have questions for all presenter. I am from the first balloon group from the first study. And after years, I strongly believe that there have to be infraspinatus and subscapularis. If these two muscles are there, you can do everything. Even physiotherapy can be enough. And how do you address the patient if you see the subscapularis still and you want to implant balloon, you want to put graft, what to do?
Okay, so for me, maybe next session I will present the result, clinical outcome with and without subscapularis tear. Maybe I can show better. I can tell briefly. For me, the reparable subscapularis tear, always I repair the tendon. Actually, around 20% in my group. 80% no subscapular intact, but 20%, around 20% reparable subscapularis I repair. Then similar result to the intact subscapularis tendon. But the irreparable subscapularis tear, around 4%. They're very, not so many, but very rare. But in that case, the clinical outcome a little bit lower. But still, I'm doing the SCR. If it fails, maybe I need to do another thing. But it's still, we can, if we do SCR alone without treating the subscapularis, but function improve and no pain at all after surgery if graft is healed.
Thank you. So you always try to repair subscap?
Yes, that is very important.
Yeah, okay. Eli?
I agree. I think you have to repair the subscapularis and then continue according. I think we have to repair the subscapularis, and if we have completely torn supraspinatus, to put a balloon.
And what is your opinion about infraspinatus?
Infraspinatus is the same. If you can to repair it. Otherwise, you should not put the balloon. Change your operation.
Okay, so next 2 sessions gonna be again about rotator cuff. So we're gonna have a lot of argument, and for the sake just of time, we're gonna keep on talking about them. And I appreciate everyone who talked. Thank you very much. Those guys.